So today's case would be talking about a single deep ulcer on the lateral border of the tongue. So as you can see in the picture below, this is a 65-year-old white male who was referred by his dentist to an oral surgeon for the evaluation of a single deep ulcer on the right lateral ventral border of the tongue. So the medical history is significant for cigarette smoking for approximately 50 years, significant for obesity, hypertension, and hypercholesterolemia. So as we said before, this man was referred by his dentist to an oral surgeon to evaluate the deep ulcer on the right lateral ventral border of the tongue. The duration is for several months. The ulcer is described by approximately about 1.5 by 1.5 centimeters. In greatest dimension, this patient has history of chronic cigarette smoking, 1 pack per day, for approximately 50 years. The lesion is largely asymptomatic unless accidentally traumatized while chewing. So the clinical examination by the dentist revealed 1.5 by 1.5 single ulcer, as we said before, that is well demarcated but heavily keratotic, as manifested by rough white surface, and there was no cervical lymphadenopathy. So an incisional biopsy was taken for investigation, and histological examination reveals 2 pieces of soft tissue exhibiting epithelial neoplastic changes invading the underlying fibrous connective tissue and the superficial skeletal muscle bundle, and it was in form of islands of variable shapes and sizes. So this histological section is at low power, demonstrating neoplastic epithelial islands of variable sizes invading the connective tissue. This histological section is at higher power. It gives us a closer look at the neoplastic epithelial islands invading the connective tissue, focusing on the cellular and nuclear morphology. And here we can see the neoplastic epithelial islands invading the superficial skeletal muscle bundles, and this is at the highest power, which is magnification by 200. So a single deep ulcer on the lateral border of the tongue should make us think of a traumatic ulcer as a differential diagnosis. But the duration of being present for several months, when combined with age, gender of the patient, and history of chronic and heavy tobacco use, are all features arguing against the traumatic ulcer. And as we saw in the slides before, the histology also does not show the traumatic ulcer histological features. A single deep ulcer on the lateral border of the tongue present for several months in a male are also all characteristic of a traumatic ulcerative granuloma with stromal eosinophilia. It occurs also at all ages, so the age of the patient fits perfectly into the age spectrum of this diagnosis, and also the site is consistent. But traumatic ulcerative granuloma with stromal eosinophilia tends to occur more posterior and dorsal of the tongue. The history of chronic tobacco use argues against the traumatic ulcerative granuloma, and the histology didn't show similar features. Infectious disease ulcer is also a differential diagnosis. But we rarely would find an infectious disease present as a single ulcer with rolled border, especially in the oral cavity. So as we said before, this man was referred by his dentist to an oral surgeon to evaluate the deep ulcer on the right lateral ventral border of the tongue. So what are the main causes or the risk factors which would lead us to having a case of squamous cell carcinoma? The main cause is smoking, and especially for that patient who smokes more than 2 packs per day. Also alcohol use, and may also result from any chronic irritation such as dental caries, overuse of mouthwash, chewing tobacco, or the use of betel quid. HPV, typically acquired via oral genital contact, may also have a role in the etiology of some oral cancers. But however, HPV is identified in oral cancer much less often than in oropharyngeal cancer. So these oral lesions are asymptomatic initially, and this highlights the need for the oral screening. And most dental professionals carefully examine the oral cavity and the oropharynx during routine care and may do a brush biopsy of abnormal areas. The lesion may appear as areas of leukoplakia, erythroplakia, and may be exophytic or ulcerated. Cancers are often indurated and firm with a rolled border. As the lesion increase in size, pain and dysphagia may result. So for the diagnosis of the squamous cell carcinoma, of course we mainly depend on biopsy and also endoscopy to detect second primary cancer. Also chest x-rays and CT of the head and neck is also a primary way to detect to diagnose squamous cell carcinoma. Any suspicious area should be biopsied. Incisional or brush biopsies can be done depending on the surgeon preference, of course. Direct laryngoscopy or esophagoscopy are done in all patients with oral cavity cancer, and this is to exclude simultaneous second primary cancer. Head and neck CT usually is done, and the chest X-ray is done also. So for the treatment of the squamous cell carcinoma, we usually treat it with the surgery alone or in combination with adjunctive therapy, including radiation, or with or without chemotherapy. And that's it. And thank you for watching my presentation, and I hope everything makes sense. And thank you.